So good day everyone. Before I will formally start with my presentation, let me first introduce myself. By the way, I am Nasruddin S. Manyal. I will present the article entitled The Microbial Diseases in the Upper Respiratory Tract. So our topic would be about the microbial diseases of the upper respiratory tract. So, under the microbial diseases of the upper respiratory tract, we have the streptococcal parents. So, let us define what is microbial diseases first. Microbial diseases of the respiratory system may occur in the upper or lower regions. The upper region consists of the nose, pharynx, and other structures such as the middle ear and sinuses. Although many defensive mechanisms exist in this part of the body, such as ciliated hairs and mucous membranes, infections are common because of the proximity to the external environment. The lower portion of the system consists of the respiratory tubes and alveoli of the lungs. Infection occurs here because of the excessive moisture and rich supply of the nutrients. And what is a upper respiratory tract infection or known as URTI? It is known as an illness caused by an acute infection which involves the upper respiratory tract including the nose, sinuses, pharynx, larynx, or trachea. This commonly includes nasal obstruction, sore throat, tonsillitis, pharyngitis, and laryngitis. While the streptococcal pharyngitis, it is known as strep throat or bacterial tonsillitis, which is an infection of the back of the throat including the tonsils caused by group A streptococcus or also known as gas. Common symptoms include fever, sore throat, red tonsils or tonsillitis, and enlarged lymph nodes in the neck. A headache and nausea or vomiting may also occur. Some develop a sandpaper-like rash which is known as scarlet fever. Symptoms typically begin 1 to 3 days after the exposure and last 7 to 10 days. Sore throat caused by pharyngitis is commonly seen in family medicine clinics and is caused by inflammation of the pharynx and surrounding tissues. Pharyngitis can be caused by viral, bacterial, or fungal infection. Viral causes are often self-limiting, while bacterial and fungal infection typically requires antimicrobial therapy. Rapid antigen detection tests and throat cultures can be used with clinical findings to identify the inciting organisms. Pharyngitis caused by Streptococcus pyogenes is among the most concerning owing to its associated severe complications such as acute rheumatic fever and glomerulonephritis. Hence, careful diagnosis of the pharyngitis is necessary to provide targeted treatment. A thorough history is key to diagnosing pharyngitis. Rapid antigen detection tests should be reserved for concerns about antibiotic initiation. Physicians should exercise restraint antibiotic initiation for pharyngitis, as restraint does not delay recovery or increase the risk of S. pyogenes infections. Sore throat and pharyngitis represent more than 2% and 5% of all outpatient primary care visits for adult and pediatric populations. Respectively, it is characterized by inflammation of the pharynx or nasopharynx and tonsillar tissues. Incidence peaks between late winter and early spring. 8% of cases are caused by viral agent, while the remaining are bacterial and rarely fungal infection. So here the example of the diseases. First, we have the viral pharyngitis. Under the viral pharyngitis, we have the rhinovirus, adenovirus, coxsackie virus, coronavirus, respiratory syncytial virus or parent influenza, Epstein-Barr virus, orthomyxoviridae. And next is, we have the bacterial pharyngitis. Under the bacterial pharyngitis, we have the Streptococcus pyogenes, or also known as gas. Next is Haemophilus influenzae, Chlamydophila pneumonia, Mycoplasma pneumonia, Arcanobacterium hemolyticum, Neisseria, gonorrhea, Treponema pallidum. And lastly, we have the fungal pharyngitis. We have only the Candida albicans. Viral pharyngitis is typically self-limiting with minimal sequelae. Bacterial and fungal infection are more severe. Streptococcus pyogenes or group A, Streptococcus or also known as gas infection or strep throat occur in up to 30% and 15% of sore throats in pediatric and adult population. Streptococcus infection can have life-threatening complication in less than 0.015% of pediatric and 0.05% of adult patients. This can be separated into non-suppurative or acute rheumatic fever, glomerulonephritis, pediatric, autoimmune, neuropsychiatric disorder associated with streptococcal infections, and suppurative peritoneal abscess, septic jugular vein, thrombolephitis, Vincent angina. Complications that warrant urgent medical or surgical interventions. Preventing complication requires antimicrobial treatment, but growing antibiotic resistance has placed emphasis on minimizing antibiotic use. Unfortunately, differentiating bacterial pharyngitis from other infection is difficult. So here the signs and symptoms. Clinical differentiation of viral, bacterial, and fungal pharyngitis is challenging owing to similarities in presentation. Sore throat, like odinophagia and fever are all common features. These symptoms typically peak within 3 to 5 days and resolve by day 10. Although some pathogen-specific symptoms have been reported, predictive values have only been formulated for gas pharyngitis. Physical findings can help guide diagnosis. Tonsillar hypertrophy, erythema, edema, or cobblestoning of the posterior pharynx suggest viral infections. Findings like upper lip edema, splenomegaly, posterior cervical adenopathy, and polymorphic rashes increase suspicion for Epstein-Barr virus or ABB infections. Bacterial pathogens might cause anterior cervical lymphadenopathy, sandpaper-like scarlatiniform rashes, tonsillar exudates, and palatal petechiae. Fungal pharyngitis present with angular cheilitis and painful white curd-like plaques or smooth red patches within the oropharynx. So here the key physical findings in the oropharynx in viral, bacterial, and fungal pharyngitis. So patients, it's said here that patients can present with some or none of these signs and symptoms. Predictive algorithms have been developed to guide investigations and prevent antibiotic. Overprescribing by assigning signs and symptoms, and aggregated pretest probability for bacterial pharyngitis. The modified center score remains the most widely used method to work up streptococcal pharyngitis. The modified center score remains the most widely used method to work up streptococcal pharyngitis. Those with scores of 1 or less are at very low risk or less than 10%, while those with scores of 4 or greater are at higher risk of 53% of streptococcal infections. Alternatively, the fever pain score has gained popularity in the United Kingdom. It predicts strep throat based on acute symptoms, onset or less than 3 days, recent or less than 24 hours, fever, absence of cough or coryza, and purulent or inflamed tonsils. Scores below 2 to 3 have to a 40% have chance of streptococcal infection, and risk increased to up to 65% with a score of 4. This approach might be equivalent if not superior to the modified center score for reducing the need for diagnosing, testing, and antibiotics without negatively affecting patient outcomes. Tonsillar hypertrophy, erythema, edema, or also known as cobblestoning of the posterior pharynx suggest viral infections. Findings like upper lip edema, splenomegaly, posterior, cervical adenopathy, and polymorphic rashes increase suspicion for Epstein-Barr virus (EBV) infection. Bacterial pathogens might cause anterior cervical lymphadenopathy, sandpaper-like, scarlatin-form rashes, tonsillar exudates, and palatal petechiae, fungal pharyngitis present with angular cheilitis and painful white curd-like plugs or smooth red patches with the oropharynx. So, the treatment, clinical management depends on the inciting cause of pharyngitis but ultimately can be separated into symptomatic and antimicrobial therapy. Maintaining adequate hydration is critical regardless of treatment strategy. So, let us define the viral pharyngitis. Treatment is conservative as this infection. So, let us begin with the viral pharyngitis. Treatment is conservative as these infections are generally self-limiting. Oral corticosteroids for 1 to 2 days have been shown to reduce odynophagia number needed to treat of 4, but they have no effect on the clinical course. Lonzanges and benzocaine or lidocaine mouth rinses also provide mild pain relief by numbing the oropharynx. Non-steroidal anti-inflammatory drugs such as ibuprofen along with acetaminophen can be used to reduce pain and fever in adults and children. Acetylsalicylic acid is contraindicated in pediatric patients owing to risk or Reye syndrome. Patients suspected of EBV infection should be advised to refrain from contact sports owing to increased risk of splenic rupture secondary to EBV. Currently, there is no consensus on length of restriction. Next is the bacterial pharyngitis. Bacterial pharyngitis treatments focus on the eradication of gas. A 6 to 10 days course of amoxicillin is the mainstay for candidates requiring antimicrobial therapy. A single intramuscular dose of benzathine penicillin G can alternatively be used if adherence is in question. The number needed to prevent one sore throat at 1 week using antibiotics in patients with A positive throat swab is 21. Historical data from before 1975 also suggests that antibiotics reduce the risk of rheumatic fever by 67%, but newer studies exploring this complication are required. Concurrent antibiotic corticosteroid therapy is not indicated, as it does not improve pain and might delay recovery from bacterial pharyngitis. Patients with a type 4 penicillin or amoxicillin hypersensitivity or rash requiring antibiotics should receive 10 days of cephalexin, silindamycin, or clarithromycin. Similarly, patients with B-lactamase type 1 hypersensitivity or anaphylaxis can be prescribed a 5-day treatment of cefdinir or cefodoxime. Cephalexin should be avoided in these patients as there is a 2.5% risk of hypersensitivity to second-generation cephalosporins. Non-hypersensitivity maculopapular exanthems might appear in 70% of ABB-infected patients after amoxicillin but do not require treatment. No statistical difference have been reported for symptoms reduction between cephalosporin or macrolide treatments compared with penicillin. Next is atypical pharyngitis. Patients with infection refraction to first-line treatments can be treated for 72 hours with amoxicillin, clavulanic acid, or clindamycin. If atypical bacteria such as an gonorrhea or Corynebacterium diphtheria are suspected, patients should be started on ceftriaxone or erythromycin. Fungal pharyngitis should be suspected in immunocompromised patients and the elderly, for which fluconazole and miconazole treatment should be employed. Recurrent pharyngitis should be treated with penicillin, rifampin, or cefdoxime proxetil. Patients with recurrent episodes of streptococcal bacterial tonsillitis or less than or recurrent pharyngitis should be treated with penicillin, rifampin, or cefpodoxime proxetil. Patients with recurrent episodes of streptococcal bacterial tonsillitis are greater than 7 in the past year or greater than 5 per year for the past 2 years or greater than 3 per year for the past 3 years. Can be referred to an otolaryngology head and neck surgery specialist for consideration of tonsillectomy. Eradication for asymptotic colonized caries is currently not indicated. However, acute flares should be treated as concurrent infections requiring 10 days of clindamycin or penicillin, rifampin, or 1 dose of pensatin, penicillin G, and rifampin. So here the conclusion. Pharyngitis is a common cause by viral, bacterial, and fungal agents. The most concerning are espiogens infection, which can lead to suppurative and non-suppurative complication. Diagnosis of the causes of pharyngitis is currently achieved through key clinical features seen in the modified center or fever pain scoring system in conjunction with RAD-T. Antibiotic stewardships and the low incidence of streptococcal pharyngitis complications suggest that treatment can be largely supportive. Empirical and antibiotic use should be limited to patients who are severely ill, have a high risk of complications, or show no signs of improvement within 5 days of presentation. So here the key points used in this article. First, sore throat and pharyngitis represent more than 2% and 5% of all outpatient primary care visits for adult and pediatric populations, respectively, although viral pharyngitis is typical self-limiting with minimal sequelae, bacterial and fungal infection are more severe. The most concerning are Streptococcus pyogenes infections, which can lead to suppurative and non-suppurative complications. Diagnosis of the cause of pharyngitis is primarily achieved using key clinical features seen in the modified Centaur or fever pain scoring system and sparingly with rapid antigen detection testing. Antibiotic stewardships and the low incidence of streptococcal pharyngitis complications suggest that treatments antibiotic stewardships and the low incidence of streptococcal pharyngitis complications suggest that treatments can be largely supportive. Empirical antibiotic use should be limited to patients who are severely ill, have a high risk of complications, or show no signs of improvement within 5 days of presentations. So that's all for this presentation. Hope you have learned a lot, and thank you for watching.